and thank you for joining us for our 6th annual Global Summit on Kidney Disease Innovations, Vox Populi. The time is now to prevent and cure kidney diseases. This summit is hosted by the American Association of Kidney Patients and in partnership with our allies from George Washington University School of Medicine and Health Sciences. My name is Candie Gagne, and I am an AAKP board member as well as an ambassador from Pennsylvania and a kidney transplant recipient. I was a hospital corpsman in the United States Navy and an OR educator before I had to retire because of kidney disease. Being part of the AAKP since 2017, I've been able to not only advocate for my fellow patients in the civilian sector, but also through the Veterans Health Initiative for the veteran population. This year's Global Summit, Vox Populi, was purposely and strategically chosen by AAKP for its historical meaning, the voice of the people. I am one of the people who has chosen to raise my voice in support of greater care, choice, and innovation in kidney care. And I am one of the voices demanding a change in the status quo kidney medicine. Over 850 million individuals across the world have kidney disease. This number is increasing at an estimated rate of 5 to 7% annually. Every year, we lose thousands of innocent lives to preventable kidney disease issues and the lack of timely access to treatment. AAKP believes both kidney disease is both a workforce and healthcare issue. The disease takes a devastating toll on human lives and livelihoods. Most people understand that kidney disease, left untreated and undetected, can lead to premature death. But many are not aware that it impacts a person's dignity and their ability to provide for themselves and their families. Kidney disease and outdated treatments can lead to unemployment, underemployment, disability, and dependency. In 2019, AAKP declared the next 10 years the decade of the kidney. The time is now for kidney patient consumers, healthcare professionals, researchers, industry, and all people of goodwill to unite our voices and demand change. We are optimistic we can and will save more lives. But to do this, we must demand new screening guidelines and diagnostics, new biologicals, and new devices. Together, we can manage and solve this growing global health crisis. The time is now for elected and appointed leaders worldwide to listen to patient voices. Governments must remove the regulatory and payment barriers they create that delay innovation and prevent timely care access. If government fails to act, we must raise our voices and demand an end to negative government determinants of health. Make no mistake, every nation is impacted by kidney disease, and millions of people are at risk. The optimistic news is that every person watching this program today can help those impacted by kidney disease and make an impact within their own nation. Although AAKP is educating patients, care partners, healthcare professionals, and policy leaders across the world on unmet patient needs. Our annual Global Summit on Kidney Disease Innovations has helped put a human face on what is now the 10th leading cause of death based on data from the World Health Organization. We have connected people across the globe in a common purpose larger than any one person or nation. Together, we have increased hope and optimism. So thank you for joining us. Your voice is the voice of the patient, and you can count on AAKP to keep amplifying it throughout the world to create change. With that, I'm honored to serve as the moderator for our session entitled Advancements in Dialysis Care, Home Dialysis Options. Our first speaker is Dr. Paul Palevsky. Dr. Palevsky, a distinguished professor of medicine and clinical translational science in the Renal-Electrolyte division at the University of Pittsburgh School of Medicine, is a true leader in the field of kidney medicine. Not only is he the chief of kidney medicine section at the VA Pittsburgh healthcare system, but he also serves as the deputy executive director of the Veterans Health Administration Kidney Medicine Program. Dr. Palevsky is known worldwide for his expertise in acute kidney injury and critical care nephrology. He has been a key player in many clinical trials focusing on acute dialysis, preventing kidney injury, and slowing down diabetic kidney disease. With over 300 articles, reviews, and book chapters, Dr. Palevsky is widely respected. It is my pleasure to turn the program over to Dr. Palevsky.
Thank you, Candie, and I'd like to thank AAKP and George Washington University for inviting me to present on behalf of the Veterans Administration Kidney Medicine Program. So what I'd like to do over the course of the next 15 minutes or so is describe the activities of the kidney medicine program at the VA with a focus on how we're trying to enhance the use of home dialysis modalities. The kidney medicine program's strategic goals have 5 pillars: quality of care for veterans with chronic kidney disease, improving access to care to ensure that every veteran who has kidney disease has the ability to get cared for it through the VA, ensuring equity of care, having a resilient system, and having a system that serves as a learning system, embedding research within the structure of the kidney medicine system. Now, I'd love to be able to cover all of these aspects of the kidney medicine program, but in the time given, I just don't have the ability to do that. CKD is a major issue within the VA. The VA provides care to nearly 7 million veterans, and the prevalence of chronic kidney disease within the VA population is estimated to be somewhere between 1/6 and 1/4 of all veterans. So we're talking about more than 1 million veterans with chronic kidney disease. The VA has emphasized the importance of chronic kidney disease and actually issued a directive in 2020. Now, the timing of this directive is about as poor as any could be, March 17th, just as the COVID pandemic was starting. But this directive has placed the management of chronic kidney disease front and center for prevention, early recognition, and management of chronic kidney disease. The directive sets forth a number of important goals. The first of these is to implement a chronic kidney disease program into the existing patient-aligned care team, primary care structure. And to establish care coordination agreements between the primary care PACs at each of the VAs and the nephrology programs. Now, we have to recognize that there are 130 plus VA medical centers, but not all of them have nephrology services. So we're also working in a way of having coordination of care between the hub facilities with the expertise in nephrology and the multiple centers where primary care is provided. The directive calls for the evaluation of patients at risk for CKD to ensure early diagnosis, to use VA-developed reports and dashboards to identify patients at risk for CKD and drive improvements in CKD care, to implement CKD education, to implement the VA Department of Defense clinical practice guidelines for the management of chronic kidney disease in primary care, and to establish telenephrology and virtual care services to facilitate the provision of care to patients living at a distance from centers that have nephrology services. So let me point out the presence of VA and Department of Defense clinical practice guidelines. We are now on the fourth version of the CKD management guidelines, and the fifth version are under development as we speak. We've had practice guidelines within the VA focused on what the primary care provider should do for diagnosis and management. And these guidelines have been present for more than 2 decades now. And this just illustrates, and I'm sure it's too small to be seen clearly, but this is the screening algorithm that is within the guideline for how to approach the patient for early diagnosis of chronic kidney disease. Guidelines that are consistent with the KDIGO guidelines and diabetes guidelines, et cetera. Now, we have undertaken a number of initiatives over the course of the past several years with primary care and informatics to try to ensure as full implementation of the directive as possible. And this includes implementation of a reminder for cystatin C testing in patients where it is medically indicated, such as patients with neuromuscular disease and other patients where serum creatinine may not give a reliable assessment of kidney function. Implementation of reminders for EGFR and, more importantly, UACR testing for the HEDIS kidney health evaluation for patients with diabetes or KED measure, and we're using the KED measure as a quality measure within primary care. Implementation of a similar reminder for EGFR and albuminuria testing as part of a hypertension reminder that is embedded in the electronic health record that is triggered whenever a patient is seen with a blood pressure that is out of control. So a blood pressure with systolic of greater than 140 or a diastolic greater than 90. Development of a standardized CKD consult evaluation template, and we have embedded within this template assessment of risk of progression using the kidney failure risk equation. Development of a dashboard for the primary care providers to utilize for panel management, for identification and ensuring appropriate goal-directed management of chronic kidney disease, and development of an education campaign using a mnemonic that we developed called Can Save, that focuses on controlling blood pressure and glucose, assessing volume status, avoiding nephrotoxin use, ensuring use of SGLT2 inhibitors and ACE and ARBs as appropriate, vaccination of patients with chronic kidney disease, and educating patients with chronic kidney disease on sick day rules. Now, as I've pointed out, we have an issue within the VA that we have the 130 or so facilities, but not all of them have nephrology services. So we have set up telenephrology programs that we're growing. And this just illustrates the current structure that we have at this point, with hubs in New England at the Boston, Providence, and Connecticut West Haven VAs, in the Indianapolis VA, and the Little Rock VA, and spoke sites that we're delivering services to. So, for example, the 3 New England sites are delivering service to VAs within their own region that lack nephrology services, but also are delivering services to the Intermountain states, such as Montana and Eastern Washington, and to Oklahoma, where they have an absence of nephrology services. And the use of telenephrology has grown dramatically over the past several years. This illustrates on the left-hand side the increase in the number of individual veterans and the number of encounters that have been provided through telenephrology, with nearly 2,500 encounters during fiscal year 23. And in addition, the growth of care actually helping us avoid the need of sending patients out of the VA into the community for care, as shown on the right-hand side. Now, let me turn to the VA and provision of dialysis. The VA chronic dialysis program has a very long history. In fact, the VA established a chronic dialysis program for care of patients with end-stage kidney disease that precedes the Medicare ESRD program. Chronic dialysis programs were established within the VA during the mid-1960s. Currently, there are more than 70 VAs that have chronic dialysis programs, as shown here on the slide. Some of these are hospital-based programs. There are a number of freestanding dialysis facilities, and several are facilities operated jointly between the VA and the Department of Defense. Now, as can be seen, there are large areas of the country, though, that don't have any VA dialysis facilities. For example, there are no VA facilities in Eastern Washington, Eastern Oregon, Idaho, Montana, or Wyoming, or North Dakota. So we have to rely on those areas that don't have facilities, and the capacity, even in the areas with facilities, is not sufficient for all of the veterans requiring dialysis support, so that we have to refer patients out to the community. And those are the number of veterans in each county who are referred out, are shown in the colors for the individual counties on this slide. We have seen tremendous growth in the number of veterans receiving dialysis over the course of the past decade. This shows the growth overall for outpatient hemodialysis, home dialysis, and acute treatments provided within the hospital. And you can see that we've gone from around 20,000 veterans receiving care a decade ago to more than 40,000 over the fiscal year 22 and 23, with very large, rapid growth during the COVID pandemic. We've also seen an increase in the chronic outpatient population, and as we'll talk about in a bit, the growth in home dialysis. So this shows the growth in the number of veterans receiving acute dialysis, and you can see the dramatic spike that occurred as the pandemic hit. More importantly, this is the count of veterans receiving chronic dialysis, and you can see the growth in blue within the VA's intramural program. We are now providing care to just under 5,000 veterans per year, but the even larger growth in the community care, going from less than 10,000 to over 18,000 veterans receiving community care dialysis in fiscal year 23, so that we're providing dialysis care to more than 23,000 veterans in fiscal year 23. Now, home dialysis has been an area that we've been trying to increase the growth, and you can see that the overall utilization of home dialysis has increased from just over 550 veterans on home dialysis in fiscal year 11 to over 1,700 veterans on receiving home dialysis in fiscal year 23. So more approximately tripling of the total population. Of that, there's been a modest increase in the growth of our intramural program, and a very large growth in the number of patients receiving home dialysis through community providers. And this just illustrates the increase in the fraction of total outpatient dialysis provided as home dialysis, increasing from about 4.5% to almost 7% in last fiscal year. So what have we been doing to try to increase home dialysis utilization? We have developed across the enterprise a work group to try to increase utilization of home dialysis. The first step was assessment of barriers to establishment of new home dialysis programs within the VA. Key issues that were identified included inadequate availability of trained nurses, inadequate space within facilities, an absence of providers, nephrologists and advanced practice providers with home dialysis experience in many of the centers, and inadequate support among facility leadership to support the development of programs. To try to facilitate overcoming some of these barriers, we've been developing VA-specific standardized procedures for the home dialysis programs. We've been mentoring new home dialysis programs by the existing programs, and this has included formalizing procedural guides for the establishment of new home dialysis programs, and assistance with training of the home dialysis nurses. And we've also been working on development of a comprehensive pre-kidney failure education program, which is we've called the COPE program, to increase patient education so that patients are aware of home dialysis as an option for care and know that they can choose home dialysis as their modality of care. We've also developed an enterprise-wide peritoneal dialysis dashboard for assessing quality of care, and this includes metrics such as assessment of total urea solute clearance, making sure that assessment is being done, assessing the annualized peritonitis rate within programs, assessing for exit site and tunnel infections, and assessing immunization rates among the peritoneal dialysis patients. So I would be remiss if I didn't acknowledge the colleagues who are playing a critical role in many of these initiatives. The first person to acknowledge is my boss and the National Program Executive Director, Dr. Sue Crowley, who has led the VA kidney program for more than the past decade. The home dialysis and peritoneal dialysis work group that's been led by Ashutosh Shukla from the North Florida, South Georgia VA in Gainesville, and the colleagues in primary care and informatics who have been helping with our CKD collaboration, particularly Warren Shu, who's responsible for the CanSave mnemonic, Scott Palevsky, who is the overall director, Amy Shah, and Jerry Osheroff. And I certainly would be remiss if I didn't acknowledge all the support that is provided to the VA kidney medicine program by AAKP. AAKP has had a longstanding Veterans Health Initiative led by your president, Ed Hickey, that has been a valuable partner for us in our goals of ensuring the highest quality of care to those who have served. So with that, I thank you.
Thank you, Dr. Palevsky, for your excellent presentation. I have a few questions for you. The U.S. Department of Veterans Affairs has historically been a tremendous champion of the principle of patient care choice for veterans with kidney disease and kidney failure, including choices of home dialysis and transplantation. Can you tell me Tell us how you see home dialysis evolving within the VA over the next 5 to 10 years in response to the needs of veterans, their caregivers, and families.
Well, as I have described, this has been a key goal of ours to increase the utilization of home dialysis to try to overcome the barriers. We would like to see growth within the program to certainly exceed our current level of home dialysis utilization, ideally to get the rates of home dialysis utilization up well above 10%, if not higher, within the veteran population. This will require both the growth of the intramural home dialysis program and increased utilization of home dialysis under community care. We are, among the strategies that I discussed, to increase utilization within VA itself. We also are utilizing telehealth, and we've been discussing how to develop centers of excellence so that individual centers, and I'll use my own VA Pittsburgh as an example, could serve as a hub to provide home dialysis services to veterans in Altoona, Butler, Erie, or even across the state in eastern Pennsylvania, where there are not currently home dialysis programs. So we're trying to be creative in that fashion. We're also seeing how we can utilize flexibility within the VA benefits to see if we can provide staff-assisted dialysis, at least in the transition to care, as has been discussed in the Medicare program, to provide a degree of staff assistance. We may have some greater flexibility within the VA, although that is still something that we are trying to work out the administrative issues for.
What lessons has the VA learned about how healthcare systems and healthcare cultures can better support the rapid adoption of new technologies and care regimes to expand home dialysis programs?
So there are advantages and disadvantages of being in a large healthcare system. There certainly are the bureaucratic issues that can slow the adoption of new technologies, but we also have the ability at times to implement the new technologies by a combination of innovation at the multitude of sites around the healthcare system, and then having diffusion of those innovations across multiple sites through the collaborative approaches that we take, and some component of top-down implementation. An example, and this isn't straightforward home dialysis, is the way that we have been trying to increase the utilization of dialysis within our community living centers, the VA long-term care facilities, so that veterans who are in the long-term care facilities, nursing home care, skilled nursing facilities, don't need to be transported long distances to receive their dialysis, but can get the dialysis right at their bedside. And while it's not truly home dialysis, it's providing the care for the veteran where they are, rather than having them spend an inordinate amount of time traveling to their dialysis treatments.
For policymakers and kidney influencers listening today from around the globe, can you give us an idea of the size of the VA kidney care program in terms of veterans patients served, and how that size population helps your research efforts?
So just on the dialysis population side, as I showed, we now have between 23,000 and 25,000 veterans who are receiving dialysis through the VA, just under 5,000 internally within our intramural program, and the remainder receiving care through the community care program, where the VA is essentially serving as an insurer and paying for the care provided through community dialysis units. We have tried, we're in the process of setting up a research program that is embedded within the dialysis program. The first of the research studies is just getting underway. It's called the Bravo trial, run through the Cooperative Studies Program, and it's a pragmatic research study that is enrolling patients both within the VA and within the VA dialysis units and the community dialysis units to test this first study is comparing two beta blockers to see whether a dialyzed whether there's a difference in outcomes between a dialyzed and a non-dialyzable beta blocker, but we can use this platform that we're building then for multiple other clinical questions to embed research right within the delivery of care.
What future innovations in home dialysis are you most excited about? And how do you think they will transform kidney care?
So there are a lot of things that we need to make simpler for our patients so that home dialysis becomes a more attractive modality. So one of the barriers that our patients tell us is the problem in peritoneal dialysis of storage of supplies and the difficulty that many of our patients have in handling the heavy bags. So that if we can move away from bagged supply to a mechanism for generating the dialysate on site in a simple fashion, we could probably decrease the barrier to for patient storage and make it easier for patients to choose to go on to peritoneal dialysis. We also need to have better technology to decrease the risk of infection. Peritonitis is very concerning for our veterans. The rate of peritonitis has certainly declined from when I began my career in nephrology to now, but we need to reduce the rate of peritonitis even further. And there are technologies being developed that will hopefully assist with that to minimize the risk of contamination in the mechanical aspects of performing exchanges.
Thank you, Dr. Palevsky, for that informative presentation.